I'll start by thanking the Society for the kind invitation. I'm going to talk about the utility of flow reserves and the current sort of evidence behind it, and what the current sort of situation is with regards to that. So the overview of the topic is role of coronary physiology in lesion assessment, use of newer indices such as FFR, IFR, RFR, and others, coronary physiology in setting of multi-vessel coronary disease. Then I'll touch a little bit on the assessment of the left main, which is very important in this particular area. And finally, FFR to guide surgical revasc and the data behind that. What I'm not going to touch on is microvascular angina, specifically CMD and other sort of modalities, which obviously are important in setting of coronary disease without stenosis. So I'll start with the example. This is a patient of mine. I did an angiogram on Friday. A 53-year-old lady came in with a posterior STEMI, non-diabetic, and without any significant comorbidity. You can see that there is acute occlusion of the OM2 branch there, which we have revascularized. She has non-culprit lesions. Specifically, she has disease in the OM1, which looks kind of moderate to severe angiographically. And she has a codominant system, but the right coronary artery is recessive in general sense. And you can see she has come back to the lab for the assessment of the other lesions. When we assess the LAD, you see that there are sequential lesions in the mid-LAD and then distal LAD. And angiographically, it appears that the distal LAD lesion is significant. So the question in terms of what we do about this lady is, firstly, which of these lesions, firstly, if the OM is significant, secondly, is the LAD in itself angiographically significant, and thirdly, whether it needs further assessment with the pressure wire. So when we pressure wired the circumflex system, what we found was that the FFR was 0.79, which means there is hemodynamic significance of the OM. But interestingly, in the LAD, this is the pullback gradient of the lesions in the LAD. Although the distal LAD lesion looks significantly worse than the mid-LAD lesion, what you find is that the acute step is at the stage when the wire is in between the mid and the proximal LAD, suggesting that the proximal LAD is very much significant as compared to the distal LAD, although angiographically, it looks like the distal LAD is significant. So it highlights the important problems with using diagnostic angiogram as a technique to guide sort of revascularization. Of course, it's common sense that the proximal lesions will be more important than the distal ones, but this is just kind of the principle of it which I was trying to highlight. Now, I was trying to practice my talk on my 10-year-old yesterday, and this is kind of what I came up with regards to the utility and the FFR in coronary arteries. So essentially what you have is the measurement of the PDPA, which we are interested in. So in that setting, the diagram on the left-hand side shows the pressure in the coronary artery, in the proximal coronary artery, which should be equivalent to the aorta. And then you have the wire which has crossed the lesion, and we're looking at something, the distal sort of arterial flow or the pressure gradient. So essentially, you're trying to measure the drop in between that pressure gradient in the functional assessment. So the FFR then would be calculated by distal coronary artery coronary pressure divided by proximal coronary artery pressure. So essentially, imagine the systolic pressure is 100 millimeters of mercury, and the pressure drop is about, say, 30. The FFR would be 0.70. So it's sort of very basic calculation in that sense. Going back here, what you're trying to do is trying to induce hyperemia in the lesion or in the coronary arteries by giving the adenosine. And usually you'll try and do that by giving adenosine, which will increase the coronary blood flow between 3 to 4 times. And what that will do is that will worsen the pressure gradients across the chart. Eventually, what you're trying to measure is the pressure difference in the E section, which is down below there, and trying to assess in the diastole what the difference is. But you don't have to do that in the what we call as the FFR, essentially. I'll come to that in a second. So In this, coming back to this diagram, what we're trying to do is trying to assess the functional flow reserve, which is the FFR, and if it is less than 0.80, that means that the lesion is hemodynamically significant based on the outcome data that we have from several studies. Now, of course, when you have a binary cutoff like this for what is a continuous variable, it's always difficult. So the initial studies looking in this area, such as DIFFER-MI and other studies, they particularly looked at a lesser gradient of 0.75. The 0.80 number has been based on primarily data from a study called as FAME. So in principle, what we need to remember at the end of the talk is essentially if the FFR is more than 0.80, that means the lesions can be left alone and are not hemodynamically significant. On the contrary, when the lesions are less than 0.80, that means that the lesions need to be revascularized in general sense. The data has been primarily derived to aid PCI, and it's quite important to remember that. So although, it is interesting data, but the whole point of the study came from the fact that there was excessive stent revascularization which was going on in a particular era. And the first major study which looked at this was the FAME study, and subsequently there are FAME 2 and FAME 3 studies which form an important piece of evidence. The FAME study, I'll talk about that because that kind of started the whole trend. So it was published in 2009. Patients were enrolled with the lesion were less than 50%. About 1,000 patients were recruited, and patients were randomized to a FFR-guided approach or a direct PCI when there's a lesion. And in terms of the outcomes, the primary outcome was death, myocardial infarction, and revascularization. And you can see that the all-cause mortality at 1 year wasn't significant by itself, but a combined endpoint of myocardial infarction plus all-cause mortality was significant. Although with mortality as well, there was trend of benefit of FFR-guided PCI. Now, there are various ways to look at the data, and one of the interesting ways would be to say that the less stents that were put in, the more benefit the patients got. So there are ways to look at the data in terms of what the data shows. But in general sense, it's reasonable to assume that if there was a pressure wire-guided ischemia that was demonstrated in a particular epicardial vessel, the patients benefited. Now, this has formed the basis of the evidence for the ESC ICTA's guidelines from 2008. And essentially, the current recommendation would suggest that if the coronary angiography shows a significant stenosis angiographically, meaning a lesion more than 90%, then we can assume it is hemodynamically significant. On the contrary, the lesions which are between 50 and 90%, the suggestion would be that we should be undertaking pressure wire assessment if there's no other form of ischemia that has been demonstrated in these patients. Now, what has become recently very confusing is these terminologies, which you will see increasingly in the heart team MDT. So FFR is a specific measure of coronary flow when we have given adenosine to the patient. Now, various companies such as Abbott and Philips and Boston, they have patented various technologies which look at different things. So in your practice, you might see indices which are sort of similar to what has been described in the slide. Things like IFR, RFR, DFR, but the cutoff value for them is 0.89, and it is important to remember that because these are resting indices, and what they do is they take away the need of giving adenosine to the patients, and essentially you get a resting index. The way that is derived is different for each of these parameters because of the patent that revolves around it, but the IFR was the one which came out first and was compared with FFR, and essentially it looks at a particular 10% diastolic cycle period, and the cutoff was derived at 0.89. Similarly, RFR, which is patented by Abbott, looks at the lowest numbers within 10% of the cardiac cycle. But I think in principle, if you remember that the RFR, IFR, or DFR should be less than 0.89, that will be kind of theoretically equivalent to a FFR of 0.80. That's the most important thing to remember. Now, I'll show a couple of examples of how this sort of technology can be used. This 79-year-old man with CCS class 3 angina, hypertension, non-diabetic, and otherwise sort of in good health, attended for an angiogram. And you can see the assessment of the right coronary artery here. The RCA has mid-vessel lesion that appears 70 to 80%, roughly speaking, 60 to 80%, you can say. But in principle, it's not a 90, 95% stenosis. The left system shows diffuse disease in the LAD that involves the proximal as well as the mid portion of the LAD. And there's a bit of disease in the diagonal vessel. And then the circumflex has got sort of a bifurcation lesion that involves the obtuse marginal and the ongoing circ branches. So angiographically, you'd say the patient has got triple vessel disease. And this is where it becomes very interesting about what the options are for this patient. So the treatment option, so in terms of the angiographic syntax score, if you were to calculate, it involves multiple bifurcations, and the angiographic syntax score would be about 30, which suggests that the patient should have a CABG in general sense. However, there are a few other options one can consider. So one would be to stop and optimize the medical treatment. Second would be to refer for CABG. Third would be to refer back to the MDT and see what the opinion is. Fourth would be multivessel PCI. And fifth would be multivessel pressure wire assessment. Now, when we did the pressure wire assessment, what we found was that the lesions of the right coronary artery, the OM1, the ongoing circ, are all non-significant. Even the diagonal by itself, despite having sort of important proximal narrowing before that, wasn't significant. And the only lesion that was significant was the distal LAD. Now, this creates a slight, change, if you like, from the existing data that we have with regard to surgical revasc. And that is kind of interesting because these kind of cases will be increasingly presented to the MDT, and then it's a matter of discussion about, what is the best treatment for this patient. So in this particular scenario, what we have is a functionally single vessel disease with diffuse atheroma present in all the arteries. The calculated or the recalculated syntax score is 18. So we decided to go ahead and treat the LAD with IVUS-guided PCI with a regulating stent, and the angina was much better. So, these kind of cases will keep on coming back and forth, and that's why, that's the reason I'm demonstrating this particular case. Similarly, it's important to analyze the left main data, which can be very difficult in terms of assessing the severity. So this is a paper from 2009, which subjected the patients to a FFR-guided approach, where essentially patients with left main stenosis that was mostly moderate were sort of divided into a FFR less than 80 and FFR more than 80, and the patients with FFR more than 80, less than 80 underwent CABG, surgical revascularization. And the outcome in these patients was similar in both the groups, suggesting that patients who have a non-significant stenosis in the left main on the basis of coronary flow can be left alone. So the question then is, what is unique about the left main assessment? Well, it's just due to the fact that there is distal disease and serial lesions, and it always is difficult to assess the morphology and the stenosis in the left main. Sometimes the osteal lesions, although they can be eccentric, and it's quite difficult to conclusively demonstrate whether they are significant or non-significant. So to give you an example of that, a 61-year-old man I'd seen in the clinic, referred to my clinic because of an exercise test that was undertaken. He's known to have coronary disease. At high workload, there was electrically positive result, but the patient was completely asymptomatic. Background history was extensive, out-of-hospital cardiac arrest, previous ICD, but normal LV function. So these are the angiographic pictures. You can see that the right coronary artery has got a stent that is patent. Patient has got ICD. On the left system, in the caudal views, the left main appears hazy distally, but there's no significant stenosis, probably a mild stenosis in these views. However, cranially, you can see that there is significant stenosis of what appears to be distal left main. And so these were the kind of angiographic images. So what is interesting here is that the FFR of the LAD was 0.81. And in fact, on the IVUS, the lesion was not in the left main, but was in the ostium of the LAD. So, there are some nuanced decision-making with regards to this, and I think it's important that we understand this data. Now, coming very briefly to the use of FFR in CABG patients, and I think it again comes up in the MDTs quite a lot. Apart from one studies, which was the IMPACT study, which looked at arterial revascularization guided by FFR, all the studies looking at FFR in patients with CABG were negative. suggesting that there is very limited utility of this technique in patients necessarily undergoing coronary artery bypass grafting, especially in the current practice. So to summarize these slides, what I would say is that FFR in patients undergoing CABG reduces the number of grafts because it simplifies the CABG procedure. So in general sense, you're less likely to put grafts on individual arteries because most of the circumflex and the RCA lesions tend to be pressure wire negative in general sense. There is no clear indication that the use of FFR improves early outcomes after CABG. There is no evidence to suggest that FFR lead to any benefits in terms of patency, because again, there are mixed results sort of looking at these studies, and I haven't discussed individual studies, but I think this is kind of the overarching summary. It is agreed that there is a need for appropriately powered randomized studies looking at FFR versus angio-guided CABG. So to conclude, our understanding of coronary flow reserves is essential to make rational decisions at the heart team MDT. It will be increasingly the case that these cases will be discussed at the MDT, and I think as a surgeon it is important to have a knowledge of this. Newer iteration of the newer techniques such as IFR, RFR can be confusing, and the cutoff of that is 0.89. Multi-vessel pressure wire guided often converts multi-vessel coronary disease into functionally single-vessel coronary disease, and of all things we discussed, I think that is the most, in my practice, most utility of FFR. If I want to do PCI, you can convert multi-vessel disease into single-vessel disease, and that is important to realize in an MDT setting. Isolated left main stem lesions do remain a challenge, and especially moderate lesions, although the recommendations would suggest bypass, are often pressure wire negative, as shown in the studies. And finally, use of FFR to aid grafting in CABG needs further research. Thank you.